You don't die from hypovolemic shock screaming. You die walking around saying you're fine, right up until your organs shut down. If that sentence made you uncomfortable, good. That discomfort is the difference between learning and dying. I'm a former combat medic from the 160th Special Operations Aviation Regiment in Desert Storm and Task Force Phoenix in Afghanistan. Today I'm going to show you how hypovolemic shock actually kills people in SHTF, why prepared people miss it, and what really matters when there is no hospital, no blood bank, and no rescue coming. Hypovolemic shock does not announce itself. It hides behind normal conversation, normal movement, and false confidence. By the time blood pressure drops, the clock is already loud. Hypovolemic shock begins when the body loses more than 20% of its circulating blood or fluid volume. At that point, the heart can still beat, but there isn't enough volume left to maintain pressure or oxygen delivery. The pump still works. The tank is empty. As volume drops, oxygen delivery collapses quietly. Cells switch to survival mode. Acid builds. Clotting breaks down. Organs begin failing in a predictable order. The brain loses clarity first. The heart loses strength next. The kidneys shut off urine to conserve volume. The gut shuts down and starts leaking bacteria into the bloodstream. This doesn't look dramatic. That's why it kills. The body lies to you by compensating. It steals blood from the skin, hands, feet, gut, and kidneys to keep the heart and brain alive. That compensation keeps people upright, talking, and moving, and it convinces everyone that nothing serious is happening. In SHTF, that lie kills families. I've watched people joke, argue, and refuse help while already dying. The quiet ones worried me more than the screamers. The ones who said, "I'm fine," were the ones we lost. Decision anchor. If someone is injured and insisting they're fine, that should make you more concerned, not less. Hypovolemic shock is especially dangerous in collapse scenarios because it often develops over hours. Someone can be injured in the morning, appear functional all day, and be dead that night if nobody intervenes early. If you think this won't apply to you, understand this clearly. Shock kills people who think they still have time. The causes are everywhere once systems fail. External bleeding from broken glass during cleanup, chainsaw accidents while cutting firewood, sharp metal from collapsed structures, or weapon wounds. A small arterial injury can drain a liter of blood in minutes. Internal bleeding from blunt trauma, falls off ladders, vehicle wrecks when roads are chaos, crush injuries, no blood outside while the abdomen or chest fills quietly from a ruptured spleen, liver, or pelvic fracture, severe dehydration from contaminated water. Diarrhea alone can strip liters of fluid per day. What starts as stomach cramps turns into hypovolemic shock faster than people expect. Large burns, especially third-degree burns, covering more than a quarter of the body. Plasma leaks into damaged tissue and never returns to circulation. Persistent vomiting from spoiled food, illness, or stress, draining both fluid and electrolytes until circulation collapses. Some injuries are survivable, some aren't. Knowing the difference matters more than gear. Here's where most people get it wrong. They think shock means blood pressure dropping. That's already late. Shock starts long before the cuff tells the truth. Hypovolemic shock moves through 4 stages. If you can't recognize stage 1 and 2, you don't get a second chance. Stage 1 is compensated shock, up to about 15% volume loss. Blood pressure usually looks normal or even slightly elevated. Heart rate creeps past 100. Breathing is just a little faster, but the body is already telling the truth. Hands feel cool even when the air isn't. Skin looks drained, like someone turned the color down. The mouth stays dry no matter how much they lick their lips. They can't sit still. They fidget. They talk too much. They crack jokes that don't fit the moment. They feel thirsty, wired, uneasy. Standing makes their head swim. Sitting helps. They insist they're okay. If this is your spouse and you wait here, you are gambling. If this is your kid, you don't get to wait. If this is your partner, you are the medic now. Stage 1 kills people because everyone believes it's nothing. Stage 2 is early decompensation. 15 to 30% loss. This is the line most people cross and never come back from. Blood pressure may still look acceptable lying down, usually around 100 systolic, but it drops when they sit or stand. Heart rate climbs into the 1-teens. Breathing becomes shallow and inefficient. The wrist pulse feels fast but thin, like it might disappear if you stop pressing. Skin doesn't just feel cool, it feels wrong. Damp without sweat, waxy. Hands and feet are noticeably colder than forearms. Fingertips lose their healthy pink tone. Urine output drops sharply. They feel weak and heavy. Vision narrows. Bright light bothers them. Nausea shows up without vomiting. They complain they're freezing when no one else is. Their thinking slips. They answer slowly. They argue. They make bad decisions and don't realize it. Decision anchor. If they're still talking but can't answer simple questions cleanly, you are already behind. This is where prepared people die, not from lack of gear, but from hesitation. Stage 3 is progressive shock, 30 to 40% loss. Blood pressure drops into the 70s or 80s. Heart rate races past 120. Breathing becomes fast, shallow, and desperate. The wrist pulse is barely there. You find it, then lose it. Skin turns gray and blotchy. Lips go pale or bluish. Nose and ears feel ice cold. They experience air hunger, ringing in the ears, tunnel vision, crushing weakness, and a sense that they're dying. Speech slurs, thoughts fracture. Urine output is nearly zero. At this point, survival depends on what you already did, not what you're about to do. Stage 4 is irreversible shock, over 40% loss. Blood pressure becomes unreadable. Pulse disappears or turns chaotic. Breathing becomes irregular or gasping. Skin turns gray or blue. The body feels cold all the way through. Consciousness fades. Organs begin failing permanently. Without advanced intervention, this ends in death. Hard rule: if you wait for blood pressure to crash, you waited too long. Stage 2 is your emergency trigger. Treatment principles come from tactical combat casualty care and tactical emergency casualty care, adapted to civilian reality. The first priority is hemorrhage control. Nothing else matters until bleeding stops. Hard, constant, direct pressure. No checking. If blood soaks through, layer more on top. Use pressure points when needed. Use tourniquets for uncontrolled limb bleeding. 2 to 3 inches above the wound, never over a joint. Tighten until bleeding stops completely. Mark the time. Pack deep wounds with hemostatic gauze like Quick Clot or Celox, and hold pressure until your hands ache. Once bleeding is controlled, you manage circulation with permissive hypotension. This is where modern medicine confuses people. You are not trying to make the numbers look good. You are trying to keep organs alive without blowing clots. A weak but present wrist pulse is acceptable. Chasing normal blood pressure reopens the bleed. Now fluids, and this is where fantasy medicine dies. If the patient is conscious and can swallow, oral rehydration is first-line treatment. This is not weak medicine. This is volume replacement the body can absorb safely. Use oral rehydration salts or a salt-sugar solution in clean water. Small, frequent sips. Dumping fluid fast causes vomiting and worsens loss. If the patient cannot swallow and you do not have intravenous access, rectal fluids are a bridge. Clean salted water, 200 to 500 milliliters at a time, given slowly. The colon absorbs water and sodium effectively during dehydration. Now intravenous fluids. If you are trained and equipped, blood products are superior for hemorrhagic shock. Whole blood replaces volume, oxygen-carrying capacity, and clotting factors, but blood requires refrigeration, typing, screening, rotation, and logistics most civilians will never have. Crystalloids come next. Normal saline is common but acidic. Large volumes worsen acidosis and clotting dysfunction. Lactated ringers is generally preferred. It is more physiologic and better tolerated in trauma. Fluids must be given in small boluses with reassessment. Flooding the patient kills clots. Now tranexamic acid. Tranexamic acid does not create clots. It prevents existing clots from breaking down. It works best when given early, within 3 hours of major hemorrhage. Typical trauma dosing is 1 gram intravenously followed by another gram, or 2 grams slow intravenous push depending on protocol. Tranexamic acid improves survival in bleeding trauma patients. It does nothing if bleeding is uncontrolled. It does nothing if given late. It requires intravenous access and legal availability. If TXA or intravenous fluids were easy solutions, shock wouldn't kill experienced medics. For most civilians, TXA is knowledge, not a plan. Positioning matters. Lay the patient flat. Elevate legs unless spinal injury is suspected. Temperature matters. Shock patients bleed more and clot worse when cold. Insulate aggressively. Monitoring matters. Pulse quality, breathing effort, mental status, urine output every 15 minutes. Now the part most people avoid. In true SHTF, some people will die even if you do everything right. Massive hemorrhage without blood may be unsurvivable. Internal bleeding without surgery may be fatal. Infection without antibiotics may kill days later. That is not failure. That is biology. Your job is not to save everyone. Your job is to maximize survival, minimize suffering, and make hard decisions early. Sometimes the mission shifts from rescue to comfort, warmth, positioning, pain control if available, quiet reassurance, not leaving them alone. This is not quitting. This is dignity under collapse. Preparedness is not about gear. It's about accepting reality early enough to act. I learned this the hard way. In Desert Storm, we chased blood pressure and made bleeding worse. By Afghanistan, we learned restraint saves lives. Those lessons matter when you are the only medic left. Train now. Stock now. Practice under stress. You don't rise to the level of your gear. You fall to the level of your decisions. This is survival. This is reliance. This is Suburban Prepper.